question, do we find more degenerative discs in lordotic or kyphotic cervical spines? And of course the answer is, we already know the answer. The answer is clearly yes. This slide of this x-ray, one that is very pathodynamic of many of the patients we see in our practices, degenerative disc disease. Wolf and Davis's law, we see soft tissue, we see bone remodeling, we see anterior spurs, we see a very thin disc, and we see from our gravity line that the center of the skull mass is approximating the middle of the vertebra instead of on the pillars. So a proposed theoretical normal curvature has been suggested to be approximately 30 to 35 degrees. Certainly it is not, the debate is not over, but we go from a general assumption about 35 degrees, and we measure that from the C2 to the C7 vertebral bodies. Also, again, the center of mass of the skull is aligned from the center of mass down through about the T1 to T2 vertebral level. Now, Harrison has gone to great lengths to define the permutations or alterations of the cervical spine, and this slide just demonstrates the various configurations we can go from. We can have kyphotic, military, and various harmonic or curvatures of the spine. The more dramatically away from the lordotic configuration, the more damaging to the structural integrity and the more dysfunction is likely to be seen. Often accompanying any kind of loss of cervical curve, and they are concomitant, which comes first is difficult to say, is forward head posture or anterior translation of the skull. So we tend to see that the head has gone forward as we measure the vertical axis line from around T1 or T2 up to the center of mass of skull, that the head has moved forward of where it's supposed to be. And this has either structurally altered the curve or vice versa. It also explains why when we do P to A drop adjustments, which may be part of the format that we need to take place to make curvature changes, that we're going to do the drop with the head in posterior translation. That is, we're going to try to reverse the position of the skull when we're doing our adjusting. So we wanted to use both postural assessment and radiographic mensuration or measurements to come up with our answers for how far off normal we are. We measure from the posterior C2 to C7 vertebral bodies, the posterior regions, and we measure that angulation. Then we do standing global assessments of the patient's skull to their torso, and we can also do that gravity vertical line on the x-ray. Again, my main focus is a brief introduction and summary for those people interested in looking into the neck deck. I highly recommend either chiropractic biophysics or Pedabon to get the extensive, full informational matrix that's necessary to do the best postural improvements. So extension traction, the mechanism of remodeling traction is to reverse the bad posture. And these two graphics just demonstrate in most human beings we see an anterior skull translated forward, a posterior translated and extended torso. So to reverse that, we have them lay on some sort of foam wedge or table that allows the torso to be pushed anterior and the skull to go into a posterior translation and extension. The pressure underneath the cervical spine affords us comfort and allows us to gain that better lordotic enhancement. Then we add resistance to that configuration to challenge the soft tissues further. If we just lay with our head off the edge of the bed, this can be very beneficial for patients, but it may not be enough to get the structural changes that we need to necessitate changes in our post-X-rays. The simplest way is to add the weight bag method. This has been the iconic cervical traction device for probably 25 to 30 years. A small weight is applied and the static held position allows the curve to be remodeled. One of the ligaments that we're fighting against is the anterior longitudinal ligament, which is that big banded yellow collagen ligament across the bones in the front. It tends to shorten with the head being forward and the curve being reversed, and it does take extensive amounts of posterior translation and extension to get it to stretch. Unlike braces, which are 24 hours a day for up to 18 months to 24 months, we don't have that option, so we do bursts of these therapeutic interventions. If daily is possible, it's most likely to be beneficial, and it may be from 5 to 25 minutes per day of these procedures to gain these kind of changes. Now, the neck deck is simple as well, and the neck deck was created in order to have another option, a viable, reasonable, and effective option. It can be used as an in-office tool that you can acclimate the patient once they have gone from the more acute nature of their pain and have decided that they want to undertake remodeling types of procedures. So we can use it in office to gain some acuity with it. It can be used for, then move to at-home use so that they can use it daily or a few times daily to help in the remodeling. It allows the proper position with the added resistance. The proper position of anterior translation of the torso, posterior translation of the skull and extension, lordotic reinforcement from the inflation tube, and a forehead strap pulling the head and holding it in the extension posterior translation position. It affords excellent comfort versus a lot of the other devices available, so that the patient isn't intimidated and you can avoid the consternation that is oftentimes endemic with patients who start to use extension traction devices. And fifth on this slide is it's a transition device. It's an excellent device to use to transition a patient from the early onsets of extension therapy into the more aggressive methods which you may need to use in office or for at-home use for patients that have more stubborn problems.